So I was asked to talk about dispatch CPR. I think that dispatch pre-arrival CPR instructions is actually the overlooked link in the chain of survival. I think it's incredibly important, and I think it's one of those things that a lot of us have missed the boat, and I'll show you why I say that. And I think we can do a lot better. So the talk I gave before was on CPR quality, really professional CPR quality, but I'm actually just as enthusiastic and excited about this topic, and I kind of vacillate back and forth, which is my favorite pick. So let's see. So what I'm going to talk about, everything again, like I said in the last presentation, everything I'm going to talk about is on this website, azshare.gov. In fact, there's a new link that we just started, which has all the 911 CPR dispatch information. Everything I'm going to talk about is on that link. So if you like any of it, please take it and use it and keep it and brand it, you name it, whatever you want to do with it. And again, that's sort of our ongoing survivor count right there. So what I'm going to talk about is dispatcher, just for short, DCPR, dispatcher CPR. What I believe, and I'll show you why, and that I think I can support that, why this is really one of the key ingredients to saving lives on a large scale in the community from cardiac arrest, and why I think that active measurement of dispatch CPR is really necessary. There's a wide variation between how you do pre-arrival CPR instructions. And what I'll tell you, what I'm going to show you is that there's an enormous disparity between identifying cardiac arrest and starting CPR in minute 1 of the call, in the first minute after call receipt, or doing it in minute 8. And as you know, time is really of the essence, and so it's almost like dispatch CPR is not a yes or no, we do it or we don't do it. It's actually one of those things that, like CPR, we have to measure it and actually know how we're doing. So I think that without active measurement of dispatch CPR, pre-arrival CPR, the process and the performance, without measuring that, we're unlikely to actually maximize survival. And I think that, I talked about this in the other talk, we can have the greatest EMS trained professional resuscitation, but if we have all these missing links beforehand, i.e. no one pushing on the chest, for the first, and I'll show you how long it is, you'll be surprised, on average, we're unlikely to actually maximize our survival, because unfortunately most of these people are dead by the time our trained rescuers with all their latest Zoll equipment get to start working. And so really kind of the idea is, how can we actually work together in our communities to make this a reality? And I want to thank Scott. So Scott helped, we wrote an article for EMSWorld with the idea that we could get this message out. And so I think it's incredibly important that we use venues like that a lot of our, our trained rescuers and dispatch centers read. They don't read, we did this, we wrote a guideline statement, a scientific advisory statement, and I think like 6 people in the world read it. And, it's just like, it had like a complete dud effect. And so what I've seen from my history, and I showed you some of the stuff we learned about EMS CPR, is that people read those, like hundreds and hundreds of people read, hundreds of thousands of people read those issues in magazines and journals, as opposed to some of these other things. And I tell you, so they did that in GEMS. They did a couple of years ago this CPR quality issue, and I was told that 200,000 people received that. 200,000 EMS and emergency medical people. I'm serious, when in some of these peer review articles, I think literally like maybe 200 people get it, and about 10 people actually read it. So I want to play a call, and it's a really short call, so I want you to indulge me again, like you have a choice.
NARCOM 911.
Yes, I have a gentleman here that's 63 years old.
You need medical help?
Yeah.
What's the address? The house service? Okay. Is he conscious?
Well, I can't get him to respond.
Okay, so when you shake him or talk to him, does he do anything?
No, this is what he's doing. I'll let you listen to it.
Okay, ma'am. Ma'am.
Huh?
We need to start CPR, okay?
Okay, so that call was about 25 seconds long. And into that call, about 20, 25 seconds, the dispatcher had recognized the cardiac arrest event and knew that she had to start CPR. And so that's what we want. It's a challenge sometimes. There's not every call. That's a call from King County. And they're really heavily invested for decades in identifying cardiac arrest really quickly. But they're starting CPR, their benchmark is within 1 minute of call receipt. And it's doable. It's a challenge, but it's actually doable. And so really what I want to talk about is how do we do that? How do we get that done on a routine basis? So I should go forward, not backward. So really this is what we have to work with, right? We talked about the chain of survival. And what I'm going to argue is these first two links are critical if the rest of the system is going to actually function. And so for all of us, this is actually a really, really important piece. And I think that most dispatchers and dispatch centers don't fully appreciate how important their role is. Like that is actually the life-saving piece that has to happen. So this really lies in the domain of the public, but also really is under a lot of EMS systems. And the hurdle here, of course, is that this is done differently in a lot of different jurisdictions. So some of the time this is under law enforcement, some of the time it's under public safety, some of the time it's under fire services, or a hybrid of both. And it's kind of, there's a mixed bag wherever you go, how dispatch is actually done. And part of the argument is that I don't really care who does it. Somebody has to be able to give pre-arrival CPR instructions. Whoever's taking responsibility for taking that 911 call, they either need to do it or be able to shunt the call very quickly to someone who can do it. And that we need to measure, again, like I talked about before, each of these links. And I'm going to show you our proposed model for how to measure that. So let's talk about bystander CPR. Why do we give a hoot about this link? Well, I talked about this before, is that we're actually operating on the very, very steepest part of the cardiac arrest survival curve, as opposed to out here, we can impact survival, and especially this bystander CPR piece is even earlier than the EMS response piece, when people are still viable. And that we know for a fact that time is really, really short, and that for every 10 minutes, every minute, our chance of survival without CPR goes down rapidly by about 7 to 10%. And this is actually why. This is actually a study published a long time ago by Bob Newmar, which actually showed that the ATP in the heart rapidly declines, and this is basically our timeline and why CPR is needed as quickly as it is. And this is the dirty little secret. So this is our urban EMS response times. And so, when you talk about response times, response intervals, who are my EMS people here? So what do people quote as their EMS response intervals, usually? Like what for most, like 90% of the calls have to be within what time period? 8 minutes. So we have this 8 minute that was kind of completely taken out of context from a paper a long, long time ago. So 8 minutes. Well, this is in metropolitan Arizona. I won't say which city, but I have a very, very brave fire chief that cares about this, and he measured this. He measured this very accurately over a year. And this is in this system, it's a high-performing system, the time from the call receipt through the primary service answering point to the first shock. And on average, these are mean times, is 11 to 13 and a half minutes. All right? And so that's the reality of what we're working with. So it's not a surprise that unless someone's doing CPR early on, it's not a surprise that we have 5% survival. And so we have to understand that this is why we need to engage our dispatch system. We need to be able to get the public to do some pre-arrival CPR. The more the better. And that, again, this is kind of what's going on physiologically. The heart starts out in fibrillation, and then by the time we actually get there, on average, and these are actually urban response times. I'm sure in a lot of rural systems, it's far, far longer. But this is in an urban, this is an all ALS urban system. This is not an anomaly. I really suspect that in most places, that's the reality of the time from call receipt to first shock. So that's one of the reasons that when we look at bystander CPR in meta-analyses of multiple studies, any bystander CPR, not even, I don't care what kind of bystander CPR, compression only, conventional, good, bad, indifferent, any bystander CPR was associated with about an odds ratio of about 2.5 for improving outcome. There's not a lot of things that we actually do in medicine that actually improve your odds of survival as much as that. And so it's really, really impactful. And we know that unless we have, we talked about this, unless we have CPR going, our chance of survival goes down rapidly. But, and this is from Ken Nagao, kind of estimated that conventional bystander CPR kind of delays your decline in survival by about, by the difference, and that with compression-only CPR, our decline is much less rapid. And so the idea is that if we can get someone pushing on the chest as fast as possible, we can improve outcomes. So what is the problem? Well, the problem is when we look at bystander CPR rates, in most places they're really low. Far less than half of the time people get any bystander CPR. And it's not just in the United States. This is all over. So there are pockets that, I've seen some data from Norway where they have like incredibly high bystander CPR rates. I think they've done a phenomenal job, but I'll argue that those societies that are, sort of really all for the greater good and all for one and one for all, that's not America. I wish it was, but it's not. So when we measured our bystander CPR rates in 2007, and I thought this was important enough that we actually created a bystander CPR registry, 1 out of 4 people got any bystander CPR in Arizona. So we had huge room for improvement, and in the CARES registry, when they reported in 2009, it was exactly the same. This last year, when they reported, it was about 31% in CARES. So there has been some improvement. So why is that? Well, I think it's multifactorial. It's probably different in different settings, but likely panic is a big piece of the puzzle. People are afraid about hurting someone. I think that's really common. They're afraid about causing harm. Lots of times it's a challenge, especially for a wife, to get her husband onto the floor. People are reluctant. In our culture, it's still socially acceptable to walk by, and we see this. I have casino videos of people who have had cardiac arrest in casinos, and what you see is they collapse right there, and they just keep doing this, keep playing, and they just look. You'll see the lady look over, and then you see her keep playing, and so it's kind of strange, but it's culturally acceptable for us to sort of watch and not jump in. That's a big piece that we have to change, is that we can't have that be acceptable. People have aversion to mouth-to-mouth breathing. People argue over the importance of this. I think that sometimes it is important. In my case, I got to tell you, my anecdotal experience is it was important. I wasn't going to do this. I wasn't going to do mouth-to-mouth with this guy. I think he had vomited. But I think in the home, with family members, people argue that it's not. People aren't as averse to doing mouth-to-mouth for a family member. I think that's probably true. And people, I think, are afraid of infection, even though that's really not a valid fear. People aren't afraid of infection. And there's a whole host of other obstacles to bystander CPR. And really, I talked about this at the last talk. Really, what we want is to simplify what we need. We need somebody pushing on the chest for those first 8, 10, 12 minutes. That's really what we need. We need somebody pushing probably as many of these red arrows as we get before EMS providers get there. That's probably our target for success. So like I talked about before, really our goal with our dispatch program was whatever we did was to measure it accurately and to kind of use the data on an ongoing basis. And so we created our bystander CPR registry, and then I told you our bystander CPR rates were not high, they were 25%. And we said, well, we can do a lot better. And in Arizona, we had a very broad public campaign for compression-only CPR, and it was not anything I can take responsibility for. It was a lot of people, at the university, and that were really responsible for this. It really was, by and large, a message. This was something we got to participate in. This was actually a project that we did where we developed a CPR training packet that went to every single school in the state, nearly 2,000 primary schools. And when you opened it up, there was a letter from the governor. There was also a letter from Dr. Avey, and I think the letter from Dr. Avey was probably more important. And then it had this video that we produced, and there was no adults or doctors in the video. It was all kids, teaching kids how to do compression-only CPR. And we called it Your Hands, Their Heart. And then you opened it up, and there was this vinyl, this vinyl thing that you put over a pillow or a basketball or whatever you wanted, because we wanted people to have something to push on. But we didn't have funds to buy everybody mannequins. But we did have a pocket CPR in it, and that was huge. People really liked this. And then the goal was to train as many people in your school as possible. And we had a few AEDs that we gave out to the schools that recorded the most people trained. And then the kids were supposed to take this home to their parents. And we trained about 50,000 people doing that with just that method. And we've had multiple other large-scale training efforts that went on throughout the state. We had in our sporting venues, this is the Phoenix Suns, this is Mr. Sarver, who's the owner of the Suns. Robert Sarver is also the namesake of the Sarver Heart Center, so that kind of helped. This is Mayor Gordon. He was the mayor at the time, Dr. Avey, and then these two gorillas here. And then we had the Phoenix Fire Department doing a demo. We had public service announcements that the governor did. Steve Nash, who was the MVP at the time, did a public service announcement for us. And then we measured. And really, what I'm trying to stress is that the measurement that's what my job was to try to measure how we were doing. And you can see that this is the overall incidence of any bystander CPR that went up to about 45% through 2010. So we had a 45% relative increase. This was significant. I mean, we moved the needle in bystander CPR, but what was really interesting was the type of bystander CPR changed dramatically, and to the point where about 3/4 of the time the public was doing compression-only CPR, and that told us that the public actually got the message. I think it was also that they liked the message. It was a message they wanted to hear, that they could do compression-only CPR. And then most importantly, we measured the outcomes during that 5-year period, and the groups that got, and this was a non-randomized observational study, but the group that got compression-only CPR had significantly better survival compared to not just the no CPR group, but also compared to the conventional CPR group. And if they had a witnessed arrest with a shockable rhythm, the survival, the odds ratio was just about 2 to survival. And so the difference, some people could say, well, there have been a lot of studies looking at compression-only CPR and conventional CPR, and some have shown equivalency, some have shown better outcomes for compression-only, some have shown worse outcomes. The difference in what we did was we actually had a formal process to advocate for compression-only CPR. We told the public, this is what we want you to do. Whereas I think what happened in most settings when they compared compression only, like in Japan when they did their whole national study, was, and they found, by the way, that they were basically at least equivalent in the cardiac arrest group, actually did better with compression only CPR. But in our study, it was the people that were doing compression only CPR were the people that were probably listening and paying attention. In some of the other studies, I think the people that were doing compression only CPR were the people that they didn't want to do everything, so they were just trying to basically do something. And I think there's actually a big difference. So again, we were fortunate to publish that in JAMA, and but the real problem was this. Right, so we were all happy that we improved bystander CPR, but if you really look at that's sort of the half is glass full, half is glass empty. Really, most of the glass was still empty. Most people still got nothing, and that's really our biggest enemy. It's not so much the type of bystander CPR. People still love to debate that and that's a big hot topic at all the AHA meetings, is what kind of CPR. I think any CPR is really what we need to get. That's really our biggest problem. So with that in mind, when you look at, and I showed this slide earlier today, when you look at, there's wide variations between outcomes between different cities. And so one of the things that might be part of the wide variation is bystander CPR rates. God bless you. And when you look at places that have, over time, really, really excelled, like King County and Seattle, what they've done is they've really focused on dispatch-assisted CPR, and they've been maniacal about it. Mickey Eisenberg and Tom Ray, they've focused on this for decades, and they've done a great job, and I learned a lot from what they were doing. But if you look at their data, their bystander CPR rates are up north of 60%. So far, far higher than anyone else's. And so while everyone's trying to sort of figure out what the secret sauce is, it might just be as really as kind of black and white as they had somebody pushing on the chest prior to their EMS, and they have great EMS system. That's not to detract at all, but that might be a big part of it, I suspect. This is important. About half of their bystander CPR is dispatch-assisted CPR. And when you look at it kind of like this, they're way up here, whereas most of the systems are right around here. At least that's where we were, and then we got up a modest improvement. But when you take away their dispatch system, they're kind of right with the rest of us. I think it's more than just a coincidence. That's my bias. And when you look at when they do dispatch CPR, it's just about as good as sort of native bystander CPR, and especially in the greater than 5-minute response interval group, it's just about as good. This is dispatch CPR, and these are the odds of survival, and that's bystander CPR without dispatcher. And it kind of makes sense because there's probably a bit of a time lag, right? If someone starts bystander CPR without calling 911 without being told to do it, they're probably just starting a couple minutes earlier. And so it all kind of biologically makes sense. So what I think is that it's not just, so you can't just rely on a dispatch system, you have to actually do both. So what I showed you was this wide public campaign for compression-only CPR that we did, but it has to be sort of linked with a very, very well thought through and measured dispatch CPR program. So you can't have one or without the other. You can't just do a ton of mass media, and you can't just have a dispatch program. Because I really think that part of this is you want the public to at least have heard about it at some point. Even if they can't do it on their own, they can't do bystander CPR on their own, at least they've heard about it in somewhere in their consciousness, so that when they ever see the event and they witness it and they have to, they're called upon, they at least can be receptive to getting instructions by a 911 dispatcher. So these are some, there are, challenges. Identifying cardiac arrest can be challenging. We'll talk about that. Rescuers definitely lack confidence. Even trained rescuers lack confidence. CPR can be technically difficult, and dispatchers can be reluctant. Most dispatchers, I don't know what you guys think, but a lot of dispatchers I've talked with, and I've kind of worked with a couple hundred now. They don't want to do CPR over the phone. It's not what they want to do. And in fact, when you listen to the calls carefully, they want that person to be alive. They'll ask them the two key questions that you heard that dispatcher ask: are they conscious, and are they breathing normally? And if you remember from that call, did that dispatcher even ask the breathing question? Did they even ask it? No. Why not? Because they heard it. They heard the gasping. So she didn't even ask the question. That person was unconscious. She heard the abnormal breathing, and she's like, okay, we need to start CPR. And So dispatchers are reluctant. They don't want to do it. People are afraid of CPR. This is another paradigm shift that we have to get over, is another hurdle, is people think CPR is harmful. And we're really afraid of what? We're afraid of doing CPR on someone that's not dead, right? Because what?
Broken ribs.
We're going to break their ribs, their heart's going to explode, something. Something bad's going to happen. And so that's actually something we need to get over. So these are some of the reasons why dispatcher CPR is so important, because we actually can breach a lot of these obstacles. A dispatcher that's really tuned in and is trained and confident can get around a lot of these things. And so this was in the little article that we put in Scott's magazine, sort of the barriers and then the ways that dispatchers can actually respond and sort of overcome those barriers. And so most of it is doable. Another key piece is the evaluation and the measurement. And so really all of this, and I'm going to show you how we measure that, but all of this is important, that dispatch of appropriate EMS resources, adherence to the protocol, and we don't yet know what the ideal protocol is, what the ideal combination of instructions and exact words to say, but what we do know is that we have to get people to recognize cardiac arrest as early as possible and to start CPR with the thought that earlier is better. And I'll show you some data that there's very little risk of harm. So what does all this mean? It actually means, like I said at the beginning, that dispatch really is one of the key links in the chain of survival. And I think probably to date the most overlooked link that we've focused on the least. It's not all that sexy. It's not that flashy. It's actually, it's hard work to train everybody, but I think there's enormous opportunity, and I think that when I look at communities and talk to people about what they're doing, we can do a lot better. And this really matters. Dispatch really matters, and again, we need to do this, or we're unlikely to improve survival without it. So that was sort of the genesis of the scientific advisory statement that the AHA put out. Was really, a lot of this was in the 2010 guidelines, but it was kind of buried in the guidelines. And our idea with this was just to have a statement that really focused on the pre-arrival CPR instructions. And the other goal of this was to make this paper sort of not so much just a statement about, sort of a science statement, but also kind of a document that gave people some implementation kind of hints and gave them some strategies. Did anybody read this? All right, I told you, nobody read this. All right, nobody reads this stuff. That's why we had to put it in EMS World. But we had lots of links. If you go to this online, you can download it for free. It was in circulation, journal circulation. We had lots of links to example protocols and to examples of good dispatch CPR, examples of dispatch CPR that could be done a little bit better or differently. And then we had lots of examples of gasping for dispatchers to identify gasping. So we've tried to make it as an operational document. And this was one of the key points. And really, what the idea is that we want to identify cardiac arrest as early as possible. And so there are algorithms out there that identify cardiac arrest, but they focus, some of the algorithms focus on asking a bunch of different questions. And people kind of debate this. There's value in really, knowing that the person's in cardiac arrest, but I believe, and the Heart Association believe, that there's more value in identifying cardiac arrest as early as possible. And the problem with asking people questions is you ask them one question over the phone that's, not a directed question, and it leads you off into the woods. And it happens all the time. And people love to throw 911 call takers and dispatchers, they love to throw them, whatever you want to call it, fake bombs, and that will lead them off of the track of cardiac arrest. And you just hear it all the time. And that was really, why we tried to focus on this 2-question model as early in the call as possible. Understand you have to get some information about the person's phone number and where they are. You have to do that. But as early as possible, with just the 2 questions, are they breathing normally? And that's really important because, still a lot of dispatch centers ask what question? About the breathing. Are they breathing? And I'll talk about that because that's a common, very, very common thing that people still do is they ask the question, are they breathing? And if you ask someone, a caller, are they breathing as they're looking down at their husband, what do they see? They see gasping. They see someone going, and the answer is what? Are they breathing? Yeah. And so then the dispatcher rightly says, okay, turn them on the side, help's on the way. And if they ask the question, are they breathing normally, with the focus on normally, it doesn't take a medical expert to look down and say, that's not normal breathing. That sounds, and it can be described all kinds of different ways, snoring, gasping, sleeping, all kinds of different things, but it's not normal. And if they're unconscious, unresponsive, and not breathing normally, that we should start CPR. What type of CPR? This is one of those things that actually in medicine we actually have some good randomized controlled studies on. This is Tom Ray's paper from King County where they actually randomized compression-only CPR or conventional CPR by dispatcher, which is different than what we did. We just had the public do the one thing. With the argument, what we argued is we couldn't randomize what a bystander's going to do. Bystanders are going to do whatever a bystander's going to do. But they were actually randomized what a dispatcher told them to do. And what they found was that survival was just as good overall in the compression-only CPR group, and in the subset that had a witnessed collapse and a cardiac cause of their arrest, survival was better. So it's really important that the dispatch CPR is not a yes or no question. It's not like is your EMS system doing CPR? Yes, we're doing CPR. It's actually a quality question. And so the quality of the intervention actually matters. And I talked about this, is the patient breathing? Yeah, they look down, they'll see gasping and they're breathing. Is the patient breathing normally? No, that's not normal breathing. It sounds like, gasping, snorting, or moaning. So how do we actually measure this? I talked about this. What we think is that this should be measured like we measure the Utstein template. So we should have a way to measure dispatch CPR. And so, you know what, everyone's always afraid to come up with something. Well, we came up with a dispatch CPR template for measurement. And is it the end all? No, but it's a way that we actually can measure the performance of our dispatchers. And it's a 1-page, very kind of down and dirty way to measure dispatch CPR and have some objective findings looking at really what we want to know is how long into the call did it take to identify cardiac arrest? How long into the call did it take to start the instructions, and how long to the first chest compression? A few other things we want to know. We really do want to know what kind of instructions were given, because we cannot ignore. There are groups of patients who have cardiac arrest that we need to give rescue breaths, compressions and rescue breath instructions. Children primarily, and respiratory arrest victims. And so we want to, ideally, we want to give them the right type of CPR instructions. So that's one of the things that we actually measure. So we do this on auditing the calls, and so we came up with a sort of our template for how we actually measure this. And again, what we hope is that some form of this will sort of become the accepted template for measuring dispatch CPR. And that this is, for the data people, the Zoll data people here, this is really important that we make this as easy as possible. And so one of the things we've worked on is getting some of our EPCR systems to auto-populate our form, our data form that I showed you, and then go to the dispatch center so that they can actually fill it out. And so that's one of the ideas that we're working on. And that this active management system, is something that we can use for other studies as well. So really some of the key points, and these are some of the really important nuances, are that we need to identify cardiac arrest as early as possible, start CPR as early as possible with the idea that there's little risk of harm. We have to be assertive, and this is a really important thing. Like a dispatcher can say, and they say this all the time, do you know CPR? Does anyone there know CPR? And what do people want? They want a way out, right? And or sometimes you'll hear on the calls, is anyone there willing to do CPR? I sometimes even hear, would you like to do CPR? So like it's sort of like, how would you feel about doing CPR? With the idea that's totally different, saying, we're going to do CPR. I'm going to help you. Let's start. And it's just sort of a Jedi mind trick of how you say it. And one of the other things is we've actually gotten away from the word CPR. And so some people have kind of told me, and this is a hard thing to quantify, but told me that the word CPR, I'm curious about my dispatchers, if you think that term kind of panics people. Some people have told me that we should not use it, even the word CPR. We should say, and this is what some of our dispatch centers are doing now, you need to do chest compressions. Let's start. I'm going to help you. Let's start. With the idea that chest compressions, oh yeah, I could do that. CPR, I don't want to do that, but I could do chest compressions. So this assertive thing is really interesting. I think part of what I've seen some really, really good dispatchers do is they sort of do this, I call it the hostage negotiation thing. Like they can calm people and they can reel them back in. Because I've heard some of these calls that you guys have to take where it's crazy screaming in the background. But I've seen some strategies about trying to calm someone down over the phone, saying, for example, saying, all right, Charlotte, you need to do compressions. I'm going to help you. Let's start. So you kind of make this bond with the person. I've heard dispatchers do that. They sort of use their first name and they sort of build this bond with them. But there's different ways to kind of sort of talk people down that I've heard. I've heard some amazing jobs of how this is done. And being really confident. That's a big part of it also. And I don't think a lot of dispatchers actually are confident with giving CPR. Again, they don't want to do this. They're hoping upon all hope, and I could play tons of calls where they're like, they know in their heart this person needs CPR, but they're hoping for some sign of life. You know, and sometimes the caller will say, well, they just took a breath, and the call taker's like, okay, all right, well, tell me when they breathe again. Okay, so are they moving? They're just really hoping that they're not in cardiac arrest, but they know they are. And then another thing is effective coaching. And so this is important. It's not enough just to say, okay, start doing compressions, keep going. You actually have to help people by, okay, we're going to do compressions, count with me. And I think it's really important to actually get the caller that's doing the compressions to count. Because otherwise, if the dispatcher's counting, you don't know what the caller's actually doing. And sometimes I wonder, when I listen to some of the calls, if they're actually doing anything. If you have the caller who's actually doing compressions count, then you at least know, you're fairly sure they're actually doing some compressions. And you want to get them to push really, at least 2 inches. You want to push pretty much as hard as they can, and to try to go at least 100 compressions a minute. So really, giving them effective coaching and continuing, because lots of times they need to do this, like I showed you, for 8, 10 plus minutes, and it's exhausting. And so realizing all this. So another thing is, sort of I talked about this, sort of the risk benefit. This is a big thing because most dispatchers don't realize that there's very little risk of starting CPR if the person's not in cardiac arrest. Very little risk. And that again was by the folks in King County, and they showed that only 2% of the time was there any kind of injury, significant injury, like a rib fracture, and there were no patients that had, any ruptured spleens or ruptured lungs or ruptured hearts, or people are always afraid they're going to rupture something. And I can tell you, I've met many of our cardiac arrest survivors, and they almost always say the same thing. They always say, man, was my chest sore. Oh, and I can think of a couple of them. One guy that collapsed on a work site, he was a small guy about my size. It was a security officer, a big lady security officer, and she was wailing on him. She was just going crazy on him. And he came in, and he had already woken up by the time he got in the hospital, and he said to me, man, is my chest sore. And I actually looked at an EKG, I looked at another EKG, I was pretty sure he must have been having an MI because he kept telling me how sore his chest was. And that actually bought him a trip to the cath lab, but he didn't have coronary artery disease. He was just sore because somebody was just jumping on his chest, but of course that's why he survived. So that's actually a really important piece, is that there's little risk of starting. And so the balance, and that's kind of why we kind of showed it like this, is the balance really favors starting. You know, the benefit really outweighs the risk of starting. So what we tried to do is, what I really hoped is that eventually someone will have a course, a certification course. And I still am hoping it. And you guys are affiliated with APCO, or know about APCO. So APCO is interested in doing this, and I'm sort of trying to kind of help facilitate an AHA-APCO collaboration where there's a training and certification process. And they both see that it's important. What it's actually going to look like, we don't know yet. But in the meantime, we decided we would start our own free training program with the goal of getting something for our dispatchers in Arizona, and now we've had several from outside Arizona come, until this formal, I think someone eventually will develop this certification course. But we put together a training course. We called it our Dispatch Academy, and this was kind of after our colleagues in King County that did the Resuscitation Academy, and we've had 2 of them already, and now we've put all the materials on the website. We've already trained about 200 dispatchers in Arizona, and we've had several come from outside Arizona, from California, and I think somewhere in the Midwest, Ohio came. And so that's really what we've worked on. And already, I'll show you, in one of our large dispatch centers, in this a very, very short period of time, we've measured, I'm sorry it's a little bit small, but we've measured improvements in those metrics of pre-arrival CPR. Kind of the one thing I'll show you is, when we started, the time to first compression was 4 minutes. And this is in a very, very well-rehearsed dispatch center that gave pre-arrival CPR, and after a very focused, intense training session, another quarter of data, the average time to first compression was about 3 minutes. So we shaved off a minute. And this was basically in about a quarter, we were able to do that, in a quarter's time. And when we first started in this dispatch center, only about less than 1 out of 5 got any pre-arrival CPR. And now it's about up to half in this dispatch center. So we're definitely improving. And so, like I told you, it's really important to measure these time intervals so that you can know, like, the time, like really what you need to break down. Is it the time to recognition, or the time to instructions, or the time to actually getting the compression started? I think it's really important to actually break down what's going on. So really, in summary, what I believe is that standardized, assertive dispatch CPR is really, I'll say, one of the key interventions to improving cardiac arrest survival on a large basis, on a community-wide basis, and that we have to actively measure this. We can't just say it's a yes or no. We have to measure it on an ongoing basis, and without this, we're unlikely to maximize our survival rates.